were just having a conversation about ethics, and I kind of went down and thinking about human subject research. Now I got to eat my own dog food. I get it.
Transfer.
It sure is.
Whenever you want to kick off in the next couple of minutes.
Okay. Do we have the? We're back to the. Oh no, here we are.
Yeah,
Good.
you're gonna be there. Yeah.
On my screens.
Yep.
I should be used to it by now. All right. This is this. Then I need to do this.
No, we're still running off the big computer.
Oh,
So you're
okay.
going to be using that, and then you got your notes up.
I got it. So
Yeah.
it's actually going to be both. All right. That's cool. Lay of the land. And you said the laser doesn't really.
Yeah, the laser only does not work with the screen.
Sure doesn't. Okay. Then I guess I'll just be animated. All right. Well, we're at 4:30, so I guess we'll go ahead and get started.
Yeah, go ahead. You can move the mic down closer to you. So.
Sure. All right. How's that?
It's working.
All right. Well, y'all, I really thank you for being here. Thanks for joining us this afternoon. I really appreciate your presence and our opportunity to share what we have been doing, what we're up to here at the University of Memphis, because as I've talked to many of y'all, people don't know about this. It's a hidden gem and of research that we're doing here and headquartered right here in Memphis. So I'm just so pleased to be able to share it. My name is Shahin Samiel, he, him pronouns. I serve as the Associate Director of Research and Studies for the mHealth Center for Discovery, Optimization, and Translation of Temporally Precise Interventions, or the MDOT Center, that's headquartered here at the University of Memphis. We'll be talking about artificial intelligence in mobile health, or mHealth, the utility, privacy, ethics, and implications for our health and well-being. And who am I? My name is Shahin Samiel. Like I said, I was born and raised here in Memphis. I actually went to campus school here on campus. I went around some of our legacy Memphis City schools, came back here for my undergraduate degree in biology, my master's degree in public health, and then started working here as a research associate in 2011, where I worked on a collaborative relationship with the university, the Urban Child Institute, and our local school district, looking at predictors of early childhood experiences, kindergarten readiness, and later academic achievement. Being a product of Memphis, and the classical risk factors, single parenthood, poverty, of which I was a product of both. What are some of the predictors that could help kids, reach school ready to learn and thrive throughout their academic careers and later life course? And then in 2015, I joined this group. They needed someone who could help with collaborative research projects, and I had just been on one for 4 years. And so I helped to bring together our 12, 13 institutions that had just started on the MD2K grant, which I'll talk about, and that was also headquartered here in Memphis. So again, real points of pride here. I work on issues like data access, data sharing, institutional review board liaison, human subjects issues, bioethics, research logistics. If you have a research question you're trying to get answered, it's like, well, what do I use and how do I get and procure? That's a lot of what I do. So without further ado, I will kind of give us a little overview. So what is the MDOT Center? Where did it come from? What has it done? How has AI impacted our research? I'll talk about a recent example, a recent study that we conducted right here in Memphis, as well as some historical examples. And then how are we considering AI for our broader center research, renewal activities, and that whole utility, privacy, and ethics bit that I promised you. And so where was this all born? It was born 10 years ago from the Center of Excellence for Mobile Sensor Data to Knowledge. We love syllables. The MD2K Center. And this was funded by the National Institutes of Health Big Data to Knowledge initiative that came from the Precision Medicine Initiative. It's kind of the whole background of where and why all this came to be, with that early vision being using mobile sensors, things that can sense mobily, right? Not in a clinic or a lab setting, but in our day-to-day lives, to improve spatiotemporal precision in precision medicine. What does that mean? Space and time, right? In other words, context. Because we always have a bunch of things that are always flying at us, right? Stress, inducements to eat in ways that won't be so healthfully, to smoke, to consume other things. So how can we detect, predict, and act on those things for better and healthier outcomes? And so again, with that vision being using mobile sensors to optimize mobile health interventions to someone's personal state, right? What's going on in their lives, their context, their time, and their individual engagement, right? Some of us have our smartphones with us all the time. Some of us at an arm's length. We all need something a little bit different, right? And so trying to design, develop, and deliver the optimal time and place for each individual and each intervention. And why is this important? Well, depending on who you ask, it really doesn't matter who you ask, whether it's the World Health Organization from this little matrix graph or the CDC, a discrete number of risk factors. In this case, we're looking at 7 risk factors like tobacco and alcohol use, high cholesterol, high blood pressure, diet, physical inactivity, and obesity are linked and cross-linked and interrelated and la-di-da there with 4 chronic diseases: cardiovascular disease, cancer, chronic lung disease, and diabetes. And under this model that the WHO has put out, you're looking at 75% of healthcare spending on these chronic illnesses. The CDC put out something else some years ago about chronic conditions and mental illness, mental health could account for up to 90% of healthcare costs from our healthcare economy. So regardless of who you ask or what metrics are used, chronic diseases are a huge deal from a health policy perspective, from a public health perspective, from a health administration perspective. And a lot of you are aware of the paradigm that in the 20th century, we made so many advances in lifespan and health and well-being from civic matters, things like sanitation, from advances in pharmaceuticals like antibiotics and insulins, from immunizations. But now we're seeing the big value add, the big push is in behavioral medicine, right? And that's even more challenging, that paradigm of the human brain. So how can we use AI to tackle these both new and timeless challenges in our healthcare? Because what are we talking about ultimately? Behavior modification, right? It's hard enough to get me to change my behavior, but now we're talking about the population scale. I'm asking you to change your behavior. I mean, I'm telling you what to do. How are you going to respond to that? So that is where we're at and how we can use AI to impact that. And so what we did in the MD2K days, which were the previous center, we looked at a number of studies and study health states. You can see that almost half of those involved smoking, but how we could use mobile sensors in these spaces to deal with things like oral health, cocaine use, opioid and pain management, behavior change. We even looked at job performance for one of our research questions. And so how did we do this? By using robust sensors, so sensors that could work out there in the field to collect labeled data. Some of these were generated and built by us. Some of these were commercial sensors, and deploying these technologies with no real subject-specific training, right? In general, I'm going to have to show you what this looks like, but the goal is, a little bit of training, but this isn't the kind of thing, it needs to be the kind of technology that you can deliver to somebody, train them in 15 minutes and let them go. In other words, a general population person, not someone who's highly technical. And what we did is we built this software platform that was called mCerebrum that existed on our smartphones. Again, this was 10 years ago, using these multiple concurrent sensors feeding into the software platform. In some of the cases, those were very high data rate sensors that we saw on the previous slide. Some were lower data rate sensors, but literally talking about tens of millions of samples coming in per day. And they would come in via wireless radio, be poured through a data quality algorithm that was not what we called artificial intelligence. That was a thresholding thing. We know what these, if you're wearing a 2-lead ECG mobile chest sensor, you know what a heart rate looks like numerically. And if you fall above or below that, a flat line or, garbage, then we know that that's not a good data quality signal. We can ping the phone, and that way our participants can know, hey, I need to readjust this thing so that we can get better data fidelity, right? And then, of course, there are sensors that are on the smartphone, including GPS and location data, feeding all that through a privacy controller that I'll talk more about later to give people the agency over their data as it's being collected. Because again, we're collecting some really intimate stuff, because then we put all of that high data rate, low data rate stuff, all of that data through the machine learning models. Now, this is where we start to get, we're starting to cook here, to create, to generate, and to validate the biomarkers of interest. Things like stress, smoking, eating, lung congestion, heart motion, location and geo exposure, closeness to a thing we've identified as maybe a health risk place, drug use. So by using that raw data, then understanding that these events have taken place, that these people have done said events, and then we can trigger on top of those to say, okay, we've identified a stress event. Maybe I want to ask you via self-report, what's been going on? What's going on in your world? An intervention to maybe calm you down, or even a performance-based test. And then, of course, using encryption, secure storage, these are smartphones, so we can beam this data off to our servers back home, and then aggregate these data across the hundreds of people in a study. So now we're really talking big data. So again, this is what we did over the past 10 years. A lot of these machine learning models, I like to tell people we were doing AI before it was cool, guys. Come on. And being able to generate and validate these biomarkers has come a remarkable, and I'll get to that in a minute, remarkable evolution in the past 10 years. And so our big value add over the traditional approach where you might get step counts or sleep or heart rate things out of a commercial device, by and large, those are in a black box of an algorithm. You trust what they give you, and you can get some really good stuff. How many steps correlated with a weight at the end of the month or sleep or whatever. But in general, that's a pretty linear approach. What we did is we took raw sensor data and used that, that big data, if you will, to develop, validate, and improve biomarkers, get them out into the research community, and then create more of a circular environment where we can identify new ones and continue the process again. And so graphically speaking, the goal being to develop these biomarkers, test them, validate them, and get them out for commercial adoption. And for example, the stress algorithms that we worked on 10 years ago via ECG and other items, now some of which exist on the wearable I'm wearing right now. And so that being pushed into the commercial environment, so that it doesn't live on a dusty bookshelf, it's actually being integrated and used in our society. The two driving biomedical applications of MD2K involve smoking cessation and congestive heart failure. And you're not going to be quizzed on this because, God forbid, there's entirely too much content up here. But again, the sense, analyze, act domain or paradigm that we used in this study was to pull these high data rate situations, run them through the machine learning, get the biomarkers of interest that were stress and smoking. Again, the smoking piece is kind of there on your right side to see how we developed an algorithm that could detect the hand-to-mouth gestures of a smoking puff, put enough of those puffs in sequence to call that a smoking episode, and objectively be able to identify that a person has smoked a cigarette. Well, why is that important? Because we wanted to intervene on people's stress when they were trying to quit smoking and to say, well, if you're stressed out, that's a precipitant of lapse. You get stressed, you want a cigarette. Can we intervene on people's stress to prevent them from then having that cigarette? And how do we test that we were successful or not? Well, we can do self-report. That's the classical way of doing things, but self-report often kind of sucks because people forget and they don't want to tell you about things. This gave us an objective endpoint that we were then able to use to see whether we did what we were trying to do. And on top of that, that biomarker could also be used in studies or in interventional components when people have lapsed. Because when people lapse, you can tell them something nice. Hey, it happens to everybody. Get back up on the truck. It's okay, rather than go back to a full relapse. So using these kinds of biomarkers of interest in direct intervention work, again, this is something we did 8, 9, 10 years ago. We also looked at congestive heart failure in developing a sensor that was a contactless radio frequency sensor that was about the size of a large phone. And what it could do is look at the motion of heart surfaces and using algorithmic machine learning stuff, delineate the different kinds of body tissue compositions, being able to discern bone from muscle or muscle from fat or body fluid from the rest of these, and knowing that congestive heart failure is a scenario by which fluid builds up in the body, in the lungs, in the extremities. We know that before someone kind of falls off that cliff of decompensation from a stable state to an unstable state into a hospitalization scenario, things change in the body, right? And oftentimes these patients are trained to take their own weight. They're going to feel symptoms of shortness of breath. You're not able to chase around your kids and your grandkids anymore. You're having trouble walking from the car to the grocery store in the parking lot. Well, before that happens, there are other changes that are happening in the body that are not so perceptible. Can this sensor detect those changes before this continues to progress? And then you can intervene on that in some cases fairly simply. Okay, please do not go back to that restaurant chain and order another appetizer that has 8,000 milligrams of sodium. Don't do that again this week. Or maybe up your diuretic because you did. And you could then prevent someone from entering into this cascade. You've improved their health and well-being because nobody wants to go to the hospital, and you've mitigated those costs. This device is in the commercialization sector right now, is kind of entering, going into that space. And so it's been a real joy to see that work has got legs under it. This matrix of 15 mHealth biomarkers and opportunities to intervene on items, from oral health to eating to different drug use, all these things barely scratches the surface. And every few months, we're seeing more opportunities come to bear, which I think is freaking terrific. And what we've done in the past few years is progress out of the MD2K Center grant into the MDOT Center grant, from where we were running studies. Now we're supporting studies. And how can we support other institutions, other researchers, other people across the country to do this work and keep this work going, as opposed to, again, it's sitting on a shelf and you've done your 5 years. Congratulations, everybody go home. NIH was very excited with the work that we were able to accomplish over those 5 years, and they did not want to see that expertise just subliming across the country, which was one reason we've continued into the space that we have. And so those CPs, those collaborative projects, and those SPs, those service projects, are ways in which we've collaborated with researchers and research groups all across the country in order to help advance their knowledge and allow them to continue in this space. And we know that over the past 10 years, we've had this rapid algorithmic into AI evolution. And we have the potential for truly ubiquitous healthcare with a personal lab in the pocket or on the body. Thinking from the previous decade to now, how we've evolved and where we will go in the next 10 years. Where will we drive AI? Where will AI take us amidst all of these other technological advances in technologies, in sensing, in battery optimization, as we're able to do more and more to detect information about people's physiology, their lifestyle, risky exposures, environmental exposures, et cetera. And we know that there are sensors being integrated into spaces all around us, increasingly, not just on our bodies, but in our Internet of Things spaces. So the opportunities are really quite profound. And we've seen over COVID, especially, the promise of telehealth and the promise of, therapy, mental health therapy, other doctor opportunities. But as we see this technology advancing, that knows the latest health research and best practices, can personalize those interventions when and where needed, and then share and consult with the provider as needed. We're seeing that in some of the continuous glucose monitoring spaces that allow for those kinds of insights and analytics to be shared directly with the patient, but also be shared with the provider. And so if there's a change that needs to happen, you're not necessarily having to wait for that, depending on the severity of the condition, 6-month, 3-month, 2-month, 1-month follow-ups. You're able to get more real-time data to inform and intervene and help patients' outcomes. And so that'll take us to what we did in the past few years with our MOODS study, which stands for Mobile Open Observation of Daily Stressors. And our major innovation in this space was using sensor-based prompting to catch people in the moment of their stressful experiences in their day-to-day lives, which helped us to vastly improve our prompt efficiency. Now, what does that mean, right? Well, if you're going to ask people a thing, and you want to know about said thing, you should probably ask around the time of thing, right? And so if you use a random prompting, say you're going to ask me about my stress at 1, 3, 5, and 7 p.m. I get stressed out at 2, 4, and 6 p.m. Well, I've really missed a lot of opportunities and a lot of effort in recruiting this participant and querying this person and burdening them so that I can try to collect the data for the research outcome that I'm trying to discover. In this case, we were able to use a deep learning AI model on the person's smartwatch to detect when the stress events were taking place, and then prompts them in real time or near real time. Say if they were driving, we wouldn't prompt them while they were driving, but to capture the essence of what was creating that stress. What was the stressor? What was the precipitant of that stressful event? And being able to use this approach for other studies to kind of advance and continue on this. So we would recruit people. We would give them a free smartwatch if they enrolled successfully in the study. We would provide them these daily annotations of stress, about 6 times a day we would ask them, and then they would get back from us weekly visualizations of their stress that were personalized to whatever was going on with them that week. And then they would fill out surveys about their week and about the visualization. And we, of course, used this AI model to do it, to do this work. This was a 100-day study. It was all virtual, and there were no financial incentives associated with this. We began developing this study in 2018, 2019. It's kind of provident when 2020 came around in developing this all virtual study. So kind of a little bit of luck of the draw there. So this was the architecture of the study, and thinking and starting with that smart watch down in the lower left, what it would do is it would detect these physiological events and share them with the phone to prompt the participant. The participant would then log their stress, and that information plus the sensor data would go to our cloud server that would then generate the visualizations, give those back to the participants. Well, that was the end of it. That was our goal. This is an all observational study. We had no intention of anything else happening after that point. We were just trying to gather the data, do the research. What we found out is that participants, based on their participation in the study and their reflection on their own stressors, and they're receiving these visualizations back from us, took part in a number of health behaviors like improving their self-awareness of stress, identifying their most dominant stressors, identifying their most stressful contexts, identifying goals by themselves to reduce stress, and to reinforce different kinds of behavioral change benefits that reduced both the intensity and the frequency of their stress. As such, we got interventional type results out of this study when we did not engineer it for that at all. Some of the screenshots from the study, you'll see kind of on the left, there were a list of different stressors in the person's day, where they were. They could annotate on there, 1 to 5 scale of they were not stressed to stressed. It would take them into a second screen where they could tell us, their semantic location, I was at home, I was driving, I was at work, and then what kind of stressor. And then there are 2 examples here of different visualizations. One of them is kind of location based. The other one is probably a graduate student because a third of them were exams, chores, running late. So we gave that information back to participants, and this is in press right now, this publication, so that we use this deep learning AI for the observational study. We did not expect changes over time. Participants only averaged about 2 minutes per day interacting with our application, but they self-initiated 14 types of behavior changes when they reported back to us at the end of the study. And we saw a 10% reduction, approximately, both in stressor frequency and intensity, which had it both at the end of the 14-week study that was both statistically significant and meaningful, looking at 10 fewer stress events per month, or on average 2.5, 3 fewer stress events per week. And what that could mean over time is a really terrific question. And we saw a 30-day, and it was a 100-day study, don't get me wrong, we had attrition, 30-day retention rate of 81%. If you look at a lot of mental health apps that are out there on the market that have over 10,000 downloads per se, they average a 3% rate of retention. So whatever it is we did, I think we did a pretty darn good job. If you have other questions about some of the descriptive statistics, I have them here for you, but just over half of the individuals completed the full 100-day study. And so thinking about what this means for people's day-to-day lives, and thinking about all of the different biomarkers we talked about, and all of the intimate spaces, places, and things that people engage with, we have taken upon ourselves to take privacy very seriously from before day one. And that we have over 10 years of experience in this realm and have engineered from a very early space people's agency over their data, so they can control what we're collecting, that they can control the level of access to data that we are allowing to get out there. And we have began giving information back into the public policy space, where we have given public comments to the federal government, where we have pursued different opportunities to help advance bioethics in the privacy space with respect to mHealth, to leverage our 10-year experience. And a tech startup that came out of the Moods approach is really pushing the envelope to see how much can we really learn with the bare minimum that's needed, taking a purely anonymous approach to data collection. What can they discover? Do we really need to collect everything that we need? And so it's been a real point of pride to see that from 10 years ago, again, this is where this is coming from the privacy controllers that we put on the phone, where people just push a button, they set some kind of duration, what type or types of sensors, they could select as many as they want. So if it's just a wrist sensor study, or if there were a chest sensor involved, you check the boxes and then hit OK. Well, who cares about that? Well, especially 10 years ago, when these technologies were much more novel and people were much more hesitant and didn't know what to expect, the last thing we wanted somebody to do was say, I'm about to do a thing and I don't want you to know about it. And so I'm going to take the sensor off. Because what do you do then? You're going to forget to put it back on. God forbid you're on the bus and you leave it on the bus. And now we're not going to get the sensors back, right? And so what this did was give people that option and opportunity to have control over their data. And we found that that helped with trust as well, because they felt like they had a role in this relationship. And that's what it is. Now we've moved to the wearable itself, where we can actually turn privacy on or off on device. And now what we've seen in the mood study, we can even do privacy after the fact, so that if we've collected an event of interest and you don't like that we collected that event of interest, you can tell us that you don't want this data included anymore. In the past, that would mean someone calling us up or writing us an email and saying, I don't want to be in your study data set anymore, right? That's a whole person lost, because it's very difficult often as a manual process to go in by participant day, by participant hour into the data stream, sanitize that. That's a much more difficult proposition. Things are, a little bit more advanced now, or they could just tell us, right? They could tell us right here. About of the 26,000 stress episodes that were detected in the mood study, approximately 200 of those, or less than 1%, were marked as private. Not a big deal from our perspective, but for those individuals, for those 200 scenarios that played out, those were important enough for someone to say, no. And to me, that is a raving success. And looking at the new frontiers, again, as to why is this important and where does AI fit into this, is we're looking at the concept of re-identification. Now, that's a generally easy proposition when you're looking at stuff like geolocation and GPS. Historically, even in the early 2010s, a lot of people just didn't have that concept of the identifiability of those data, that those data were really sensitive to where you are and what you're doing. In fact, if I ran those GPS coordinates that stayed pretty static for about 8 to 10 hours overnight, that might be your house. If those GPS coordinates during the day, that might be your workplace. And boom, I know who you are, right? But even still, back then, graduate students, investigators, institutional review boards, they didn't have the same understanding of that. We all had to learn together, right? Well, we're looking at a similar concept or paradigm playing out with mobile health data, that for many years, wearable wrist sensor data, the accelerometer and gyroscopic data that give us our step counts and we're able to give us the hand to mouth gestures of smoking, we have all considered to be de-identified. And that's not identifiable back to a person. Well, our team looked at that and we said, well, is that true or not? How can we characterize this risk and mitigate it if it's the truth? And why would this matter? Right? Well, let's say Alice wears an activity monitor to participate in a wellness program for her insurance to get lower rates. Could the company then use the data that she's provided them and match that with data from open data sets? Because that's what we're all about, open data science, right? We get data of, by, and for the people. We need it to be out there to train these models and for other people to replicate this research. Can they then go back and learn things about Alice that Alice wasn't necessarily willing to disclose or thinking she would disclose before the fact? And we're already seeing a roundabout dynamic of this happening. It's not quite with mobile health research, but even in the New York Times of March of this year, there was an article entitled "Automakers Are Sharing Consumers' Driving Behavior with Insurance Companies." So even if you choose not to sign up for the Drive Safe and Save or the whatever, where you opt in and you download an app and all that, maybe if I'm insurance company X, maybe I'll just go to the auto manufacturer and say, I want to know all of the metrics that our fancy new smart cars are collecting about us. Did we all read those privacy policies when we drove that car off the lot? I know all of us here did, right? We all did. And then just pull those data and say, I'm not so sure I like this person's braking style or their acceleration style. They seem to have a little bit of a lead foot. And so regardless of whether you opted in for your data to be shared or not, you might get that next insurance premium and be like, whoa, what happened here, right? That is a very low tech, it doesn't sound low tech, very low tech example of what we're looking at. And so are we just blowing a bunch of smoke here, or looking at, scales are in minutes, if you have a training data set of about 60 to 90 minutes, and then you have about 10 minutes worth of someone's sensor data to compare to that, The blue line represents the 80% probability of re-identification. The yellow line represents the 90% risk of re-identification. I don't need a lot of information to re-identify you with these risk sensors. I don't need a whole lot at all. In fact, if you look at the different activities and how they all contribute towards the risks of re-identification, about a full day's worth of sensor data, and by that I mean like 8 hours, yields about a 96% risk of re-identification. And why is that? We called it the wrist print paper after all. You think like a thumbprint? Do you have a wrist? You've seen me up here, right? I do this a lot. We all have our own mannerisms, our own ways in which we conduct our wrists. Thinking about this is important because open data science, like I mentioned before, is increasingly expected, right? If you are funded by one of the institutions, National Institutes of Health, National Science Foundation, that's our money, right? That's government, that's from us, the people. We expect that the data that would be collected to then be utilized to the maximum extent possible, to be used by a bevy of researchers to understand new findings, to be available for AI algorithms to train on and advance science. But where are the risks and how can we mitigate these risks? And so this is a space in which we're actively operating in ways to think about how can we mitigate these risks. Now, gratefully, our team is full of really great people all across the country in a number of different domains. And our transdisciplinary team is something that is one that I'm super proud to be working with and for, because we are thinking about these and so many other issues, and that this is one very small example, the things I've talked about today, of how we bring all of this expertise and experience across the country together in order to leverage the work that we've done and get it into the hands of folks who can operationalize it and really find good insights that can help people's health and well-being. And here in Memphis, I know that we could not have built this infrastructure or done all this work without a team of amazing staff, researchers, support folks all across this campus, our FIT admin people, all of us working together in order to make this happen is a real point of pride. And I represent only one of many people who's worked behind the scenes in this fun, dynamic, scary, and courageous research space. Now, of course, like I'd said, we really are against keeping any of this stuff a secret. So we've put out a number of training activities that are diverse array of opportunities with different spans of commitment. Our training institute is a very intensive opportunity for people to actually come in and experience a multi-day deep dive into mHealth technologies to become more proficient with them, so they can take those back to their institutions and figure out different ways of using them to apply direct scientific applications. We also have lesser commitment situations that we put out webinars and training materials onto our mHealth Hub website, and different kinds of ways that people can become exposed to the many myriad different domains of mHealth and ways in which it can be applied. So we love getting this information out there. We have collaborative opportunities for researchers who are really considering, how could one leverage the Mood software platform or something like it to answer specific clinical research questions, specific outcomes of interest, and an opportunity to expand the access to these mHealth research tools. So if people are interested, and we have an open doors, reach out. Again, we're trying to avoid any of this being a secret. And here are links to some of our websites and resources. A lot of the stuff that we've developed is now legacy, because some of what we've done that's 10 years old is not necessarily as applicable now, but it is all open source. And the goal of that being that people could look at it, people can analyze it, people could potentially even use it in their own considerations and projects. But that concludes the presentation, and I'd love to hear any questions you guys have.
On one of your slides, by the way, thank you for the presentation very much. You mentioned deep AI. How would you define deep AI?
So this was a deep learning artificial intelligence that we use. And what we would do is it personalized the stress detection based on the individual baseline or physiology of the person. So when we gave the person the sensor and the instructions on how to get the software installed and all that, it would need a couple of hours, not really a couple, some hours to days in order to really learn the person. what does your physiology look like? What is your baseline? And the deviations from that would be the things that we could identify as the physiological arousal that we would then call a stress event. And of course, being able to filter out confounds like most commonly physical activity. So if you're in the middle of doing something physical, we're not going to be like, oh, you're stressed, let me try to intervene, or let me ask you what's going on. It would be personalized sans confounds to the individual. That's a terrific question. That's what we're trying to tackle right now. And there are a few different areas when we're talking with collaborators and talking internally about the different ways we could look at this. One area we're all very interested in looking at are the clinical outcomes. So we know about stress. We know stress. Why do we look at stress? Because stress is a killer. I mean, stress is killing, all of us, and is, high stress individuals, the higher, correlations with the higher levels of cortisol and higher levels of inflammation and higher levels of cardiovascular disease, We have the model, right? But to have the evidence and to be able to say that stress reduction exercises, stress reduction interventions can yield better clinical outcomes is something evidence-based we would very much like to build. So that would be one potential dimension. Other dimensions are how could we apply this in a different set of utility? One of the studies that predated MD2K that was really one of the most fascinating ones, even though it was really kind of cobbled together with duct tape and bubble gum, was a couples study that looked at couples. They would wear the chest sensor and it would detect stress events, and then the data would get plotted out visually, and the couples would come back into the lab, and you'd kind of have a time axis, and this is when person one was stressed, this is when person two was stressed, and this predated my being here, so I'm hearing this is secondhand representation of the story, but that the insights that these couples gained and the empathy that they got from each other and saying, oh, when we had that argument, you were really stressed out here, or going to the grocery store really freaks you out. I let me go instead, whatever.
Have you been lately?
To the grocery. Oh, we're still being recorded.
Yes.
I'm not here right now. No. So thinking about how could we potentially replicate now that that's between 10 and 15 years old, now that we have this. So there are a few different areas, but we're always looking for new creative ways to try to leverage this technology.
So I use one.
Me too. Yeah.
It actually helps. So like if I know that my sugar is running high, I'm not going to Starbucks.
Right.
Right. So it has actually done behavior
Yes.
modification for me.
Uh-huh.
And it's been awesome. And it's like, what else can you do? So it's kind of like, oh, do I really need to go to McDonald's?
Right.
Right. So the next thing is like, how is that going to do for your diet in
Right.
general?
Right.
And it's interesting to where you can go with this. Because like I said, it's me deciding I'm not going to get Starbucks, but if I do, I know what's going to happen. It's going to go high, and I'm going to get my little alarm going off. And,
who's going to pay for this? Is this like either worrying well, or is this enough clinical value that insurance companies will see it as increasing their profits?
And that's a whole other step. And I'll say, candidly, from my position, that's a question that is a little bit outside of my pay grade. However, I have opinions. That is a level of evidence that has to be conveyed. And I would say, I'll self-disclose as another user of said technologies. There is I could eat whatever I want, and now I can just have to do the mathematics of insulin to blunt that curve, or have that value add of, ooh, I'm having not so good a day, I'm stressed out, I look at a piece of bread, my blood glucose is 200, I'm not going to go get that. And with the outcome being, and you have to kind of convince them that what's better. Do you want to pay for these sensors on a 30 or 90 day basis, or do you want to pay for my kidney transplant in however many years? Many times they don't. Many times they don't. But that's the argument I think that we have to set out. And this is that's the research question we have to answer.
how much is that going to cost versus how much are you going to,
It's gonna be like Flora Read.
Mhm.
It collected a lot of neat data, but it really didn't have much clinical value.
And
It's like right
keeping-
now, I think like the Ozempic and the Mounjaro, those pills that are helping people, or the shots are helping people weight, keep their sugar under control. They're expensive even with insurance. It's, like $1,000 a month.
And we see some states even pulling back from coverage on those. And so that then becomes a question outside of my pay grade, and one that is one we all have to answer, I think, as a collective and as a society. What does health and well-being look like? What are the tools that we have in the toolbox and that we make accessible to what strata of people or everybody in terms of advancing their health and well-being? Because as we saw from 10 years ago to now, and where we will see in the next 10 years. And that's a decision I think, again, we have to make.
This
What we did here, like the mood study.
yes,
Yes, that was its own application.
Okay.
And it did integrate like via Wear OS, for example, but it was its own standalone application.
Okay. And then I'm seeing the Android applications. Are there existing iOS applications?
This application was cross-platform, the Moods was. The pre-dating applications, those were all on Android for iOS reasons. Yeah, but so those legacy applications, those were all Android. The Moods was both. Right.
Versus I would embrace more, I have a large language model that keeps up with my stuff, and then the insurance company hits me, just like you select your health insurance, you have like 3 packages, and your language model evaluates the 3 and directs you to one without giving the insurance the actual metrics of why that is the best fit
Right.
for you. So is that where it's going?
I think that is a direction it could go. One of the what is that? The methodologies that we're trying to put together for one of the new iterations of the study would be, can we have a study contained large language model that would be particular for a study, and that way we can have more control over the content that it spits out. Obviously, I don't want it to give you an intervention that is garbage or harmful in some way. So, and we're seeing, I think, with the latest iterations of phone operating systems moving in that direction toward that personalized component. I do see it moving in that direction, but we'll see.
Got a lead foot, so therefore your insurance gets renewed and it's up 25%.
Mhm.
So it's the same thing. It's like, okay, you said you're gonna cut back on, get back on your program for
Mhm.
your diabetes or your obesity or whatever, but you didn't.
Mhm.
You haven't lost weight, so therefore we're going
Now
to
what?
penalize you.
Right.
So there's some considerations there that you kind of have to, how much information do you give to corporations versus anonymized information that's like, yes, we have 2,000 people that are in the study, or else it's small number, but you know what I mean? And how are they over trends?
Right.
So,
And those are questions that we as a society are going to have to tackle. These are questions that Congress has, in many cases, yet to tackle. These are questions that are a matter of technological and privacy literacy that we're seeing in every case, in all of our societal things, is lagging behind the cutting edge of innovation. And that's a natural component. But I think that also puts more of an onus on us as members of high tech literacy communities to be those ambassadors and to be talking about this, to have these conversations, to talk about the pearls and the pitfalls of the options laid out before us. Because it's through education and through these kinds of interactions that we're going to figure this out, because we don't have any other choice. It's going to keep growing, whether we choose to talk about it and innovate with it or not.
Yeah, one more question, then we're gonna have to wrap up here, but yeah, one more, last question. Jason.
On the partnerships that you did you do anything with maybe physicians or any kind of portals, like health portals? Asking because if the individuals are looking at, then I'm getting my information from this data and I'm working with my physicians, kind of like you mentioned in the COVID era where, I'm able to talk to the physician or to these telehealth visits. maybe that versus the insurance company, has anything like that been done versus being?
We have had collaborative investigators who have worked and continue to work in the electronic health record space. A lot of what we've done with some of these use cases have been standalone. They haven't necessarily even been necessarily appropriate to share back with a clinical setting versus a research setting. But as we've heard with respect to some of the continuous glucose monitoring, we're already seeing some of that happen where you can share that information back if you choose in real time. So the opportunity and it is happening. The opportunity is there and it is happening. And that's moved very into a telehealth situation. So you don't have to go into that lab and like, okay, I'm supposed to sleep here.
All right, well, let's give it up for our speaker. Thank you so much. Great session. Thank you so much. And our recording for this session will be online. It'll be on our FedEx Institute of Technology webpage. Just go to the homepage, click on events. You'll see 901 AI, the meetup on the left-hand kind of asset over there. You can click and see this recording plus previous recordings as well. And a couple of updates, just programming updates. We have a few minutes. So in August, we'll be hosting 2 sessions, actually kind of back to back. One will be our 901 AI meetup on August 21st, same time, 4 o'clock, 4:30. Sorry.
Actually, it'll be in the morning.
Oh, that's right. I'm so sorry. Brent, why don't you come up here? Yeah, it's going to be a morning breakfast. We'll serve breakfast. It's a breakfast session. It'll be upstairs on the 2nd floor. It'll be 8:30 to about 10 o'clock that day, or 8:30 to 9:30, something like that. And then the next day on the 22nd, we are doing a AI conference, one of the first ones in Memphis, if not the first one in Memphis.
Cybersecurity.
Where our folks will be are on cybersecurity and AI. It's $25 to get in if you're a non-student participant, but you'll get a T-shirt and you'll get to meet a lot of cool people, a lot of cool
Sign up
sponsors.
by July 31st.
Yeah, so you have 2 weeks from
Yes.
today.
Is it online?
Yes.
Yes,
It is
yep,
online.
It is online. You again go to that same link. There'll be a link on the left over there for the conference, and we are looking for the rest of the year. We have speakers lined up for September and October, and we are going to be putting that information out there on the website as well. In our last meeting, sorry, this is the last point. In our last meeting, we were asking for volunteers or people to serve on a steering committee or any types of programming committees, anything like that within the AI 901 AI meetup. I, like the smart individual I am, forgot to put any contact information as one of the questions on the survey. So people submitted, and I had no idea who submitted anything. Trust me.
Thank you if you did.
Yes,
submit.
thank you if you did.
But
I-
I had to talk to you.
I checked the information twice, and I was like, no. Brent's like, no, you had to put some. No, I literally just said, hey, do you want to serve? Cool. Put this information. I had no idea who anybody was. So after today's session, within the next week or so, we'll be resending that survey out. So if you are interested, it's going to be that information's. No, that's
That's
sorry
true,
about that.
Denise,
Yeah. It'll be the contact information is just first and last name and email, and then we'll just reach out to you after the fact sometime in August for that. So yeah. With any other questions, we look forward to seeing you in August. And if you do have questions, reach out to myself and Brent. Thank you so much.
Yeah, thank you. And sorry for the noise back there.
Thank you for setting all this up for us.
Oh,
You're welcome. Yeah.
Great.
We enjoy it.
Thank you so much.
Hey, thank you, sir. Appreciate it. That was great. Good question. Did you guys develop your own LLM, or did you
Yeah.
have to did you like read like it was white label or something like that?
It was populated